everyone. Thanks for joining us today for another Sagely Health webinar. Today, we are going to be talking about second opinions in cancer. As always, I am joined by Dr. Jason Sager. Jason, how's it going?
Doing well. Thanks, Jeremy.
So, the subject of second opinions is a complicated one in cancer. So I'm hoping we can kind of break it down for people and talk about when people get second opinions, how that goes, what Sagely Health does, and how we do that a little bit different. So let's begin. If someone is diagnosed with cancer, do most people get a second opinion?
Yeah, it's a good question. And again, I hearken back to the fact that when people are getting diagnosed with cancer, the world is swirling. There's a lot going on. It seems like even getting one opinion is nearly insurmountable. The literature would say that most people are not getting second opinions. I think it's perhaps 20 or 30% on average that folks are getting second opinions. And, and there's usually a few different reasons that patients will get second opinions. The first being when the cancer diagnosis itself is somewhat uncertain. There are times that, the pathology or the testing comes back and they say, well, we think it may be, this type of tumor, but we're not sure. Maybe it's that type of tumor. If they're rare tumors, the local place, the cancer center may not have the expertise to say, or there may be a national center that's really well known for a specific type of cancer and they want that center to review it. So there are legitimate reasons why in the cancer diagnosis, folks get second opinions. And I think most patients think about second opinions in that context. What I think is really, go ahead. Yeah.
I was just going to say, what's interesting about that thing is your oncologist or whomever you're speaking to, they're showing uncertainty. They're admitting to uncertainty. So that must make it very easy for a patient to say, I agree, the second opinion, because you're not sure, and therefore it's very clear to get a second opinion. I imagine that's not always the case.
Right. And actually, as you just mentioned, it's almost as if the oncologist is leading the second opinion, right? Hey, I need a second opinion here, or I advise you to get a second opinion. Tell me with what we might do. That's a whole, again, that is something that happens. And again, that's mixed into the bucket of second opinions. But I wanted to focus today on actually a different reason to get a second opinion, something that I think is much less promoted or spoken about by the primary oncologist. And that is when considering what options for treating the cancer. And here, the reason that it's less done is because there's a source that community and basically, official, licensed oncologists use. It's called the NCCN Guidelines. It's a great group, and they work hard to put together what is considered the standard treatment for each cancer type. And I think there's like 58 or something publications that they create. The doctor looks up what that is. And if you were to go any other doctor, they basically only have that same source to look up. The only exception to that is when that doctor has something like a clinical trial or an innovative approach that isn't in the NCCN. So, most of the time, patients who wonder, well, gosh, is that chemotherapy really the right thing for me? Is there anything else that I don't know that I'm, uncomfortable with? They might ask for a second opinion, but they're choosing those doctors at somewhat at random, and they may even ask their doctor, hey, where should I go for a second opinion? And while that's fine, I wouldn't expect any other doctor to necessarily give a separate opinion because, again, they're using the same resource to determine what the treatment should be. And secondly, there's also issues with they don't want to go against the other doctor. And this is all documented in literature. I think 70% of the doctors won't give a different second opinion because they don't want to, counteract the first doctor. That being said, If they have a clinical trial, it's different. And so the real key is, can the patient find a doctor with an innovative therapy or a clinical trial, something that is different than what's being offered standardly, that patient should, that patient can access. And then I think it's a wonderful thing to go to that doctor and ask the question, should I get the standard or should I get the special thing that you've got? If they say get the standard, you almost are sure that you should get the standard. If they say it's the special thing that you got, then you can invite a conversation with the first doctor to say, well, which of these is potentially better for me? And to me, that's the best way to come out with the best possible outcome. And that's what we focus on at Sagely Health. So I know it's a sort of a complex subject matter, and we'll kind of unwrap it and unwind it further, but that's sort of just the initial outline.
Yeah, that makes a ton of sense. So let's talk about just any given oncologist. They have the NCCN guidelines. It's kind of like a flow chart where they look at the diagnosis and different diagnostics that might come from that, and it leads them to treatment. So how much latitude does an oncologist have? I mean, you mentioned that they may have a clinical trial available, but really, how do they make their treatment decisions?
Yeah. Yeah, and the fact is that the NCCN guidelines are also guidelines that are sort of ingested and basically blessed by insurance companies. At the end of the day, right, a doctor can prescribe any medicine that is approved at least somewhere for some disease by the FDA in the US, but the things that restrain them are, one, like, well, what are the experts? What does the group of experts think is best for this patient? It's part of the standard of care, not the new stuff, but just the standard. And then secondly, what's the insurance going to pay for? Because otherwise, anything that the doctor writes, it's fine, but then the insurance is not going to pay for it, which mean that it's much harder. Patients would have to pay out of pocket. They might have to, the doctor may have to apply to the company to get a coupon or to get a rebate or a discount. All of these things take time and enormous amounts of effort. The system does not make it easy. So much easier to just look up what the NCCN says. It's very likely approved by insurance, prescribe that. And usually there is an initial therapy and a second therapy. And then after that, it becomes very weak or, not at all. And so that's why, when cancer patients go to their doctors, most of the times they'll have an answer of what they should be treated with at first, and maybe even second. After that, not so much. Again, different cancers are different, but it starts to trail off. And they may hear in their doctor some, well, let's see what happens at that time. And then they start to struggle a little bit with what to get next.
Right. So we were talking about the idea that oncologists may have another option being a clinical trial. So in what cases would an oncologist have access to a clinical trial?
Yeah.
Like why would they be able to offer that and another oncologist could not?
Yeah. So while there's this whole world of standard therapies, and again, mostly old-fashioned chemotherapy that's used in different combinations that are being offered to patients all the time, there's a whole other world of research and translating that research into new therapies. Only 3% of patients are able to access that innovative therapies today. But of course, those innovative therapies are born on the backs of the traditional therapy. So it's not like you're just taking a random shot. No, they're building on what's worked already and adding other things and different things to work better. So the chances are that you'll do at least as well, if not better, with the innovative approach. So the problem is that innovative approaches are not in all doctors' hands at all times. There are a select few centers that are usually chosen, and they're somewhat, randomly or sort of, situated all across the United States. So a trial may be at 3 cancer centers and another trial at a different 3 cancer centers. They'll actually companies will try not to overlap. So they'll try to really spread it out, which means that if you're choosing a doctor at random, the chance that you're going to pick a doctor who has an innovative therapy option that matches you is quite rare. It's about 3% of cancer patients, which is why you get to the 3% that actually get access to these things. 80% of patients are interested in these things. But again, it's really about aligning those stars and how do you set this up for success. And that's where we've built the technology to figure out who's got what. So then when we have a patient come in, we can advise them and guide them to select a doctor for a second opinion who's likely to have an innovative option to offer in addition to the standard of care.
Yeah, so there's a few things that need to be true in order for a patient to even have access to a clinical trial. They have to end up in an oncologist office that is associated with a medical center that is offering that trial. That's one. Two, that oncologist has to know about that trial being run. And so one of the things that we've been doing at Sagely Health is we're trying to get you to the oncologist that's actually involved in that trial so that we can make both of those things true. We know that oncologist has access to the trial, and we know that oncologist is aware of the trial. So tell me a little bit about who are these oncologists who are running these trials, and how are they different in where they are and how you find them?
Yeah. And the fact is they are no different in their training or necessarily specialty than any other doctor. And as I said, a doctor may be, running trial A, B, C, and another doctor is running trial D, F, and G, and so, there are generally some sort of commonalities, which is that the clinical trials generally go towards more of the larger cancer centers, the ones with those reputations like Dana-Farber or MD Anderson or Memorial Sloan Kettering or Mayo Clinic. But again, it's very general. So even amongst those that I just mentioned, one may have a trial for a specific patient and another 3 or 4 may not. And so again, you can't really just go based on reputation. I do think that it is, more likely if they are an NCI accredited cancer center, which is sort of an approval status that gets you to acknowledge, the government acknowledges that that's a center that's doing research, clinical trials being in that bucket of research, clinical research. But again, it's better to actually know exactly what you're going in for, because even if you wind up at the center, if you don't wind up in front of the doctor who actually is running the trials, especially at the larger centers, they may not even know what is going on in their own cancer center with a different doctor's group. And so it's best to get in front of the very doctor who's got that clinical trial in their hands and ask the question, is this reasonable to consider?
So in today's kind of COVID age, or post-COVID, pre-COVID, whatever we are,
hopefully soon.
This idea that do you have to physically go and be like, say I wanted to get a second opinion because there was some guy across the country or some gal across the country who was really specialized by cancer. Do I have to pick up and get all the way there?
Right. No, actually, that's one of the advancements we've seen over the last couple of years, largely because of COVID, is sort of the growth of virtual second opinions. Now, it doesn't mean just because you can tune in to Zoom or a video conference and see the doctor that there's not other things that have to happen, such as getting them the medical records. They may or may not need to review the actual pathology slides, the sample of the tissue, the biopsy or the surgical specimen that was taken to confirm that's the actual cancer. There's a number of things that will have to happen or may need to happen before you get to talk to that doctor. So it can still take time and certainly some effort, and but the fact is that patients no longer, and I think it's a great advantage to be able to talk to doctors. Now, the only caveat I would mention is that if you align and find out, that doctor has a great, offering an innovative therapy treatment for me, then likely you'll have to go. So they can't transfer that innovative therapy to a different doctor to have them do it. One day, that's what we hope will happen, but today that's not the case. So the upshot is that you can find out virtually whether or not there's a match, and that's really helpful because you could have 2 or 3 of these. But once you make a decision, you'll have to get treated most likely by the doctor who's offering you that innovative therapy, compared to standard, which anyone can offer.
Great. So let's talk a little bit about how a patient that arrives at Sage Health, how do we choose the recommendations that we make for where they should go for these second opinions?
Yeah. When a patient comes to Sagely Health, we evaluate their specific situation, and it goes to what type of cancer they have, but there's also a number of other determining factors. And in other sessions, we've talked about the importance of next-gen sequencing, genetic analysis of the tumor, which can really identify some of the drivers, what genetic mutations or alterations are really causing this tumor to grow. And so knowing those ahead of time help. We can do it without, but knowing ahead of time helps, because there's these doctors who specialize in these various genes. And when you get in front of one of those doctors, they're really passionate about helping patients with this sort of chosen field. And so from our perspective, once we have that information from the patient, we then align it with the entire world of research. And again, there's 13,000 trials going on in cancer at any one point in time. But because of the technology we've built and the work that we do on a day-to-day basis, keeping that system up to date, we know on a minute-by-minute basis exactly what's going on and where. So we can basically pick the best possible treatment or treatment options for a patient, to then ask that question in a second opinion of the doctor to see, do they think it's reasonable to consider? Is this a good idea? And 90% of the time or more, the answer is yes. And we win, and the patient wins at the end of the day.
Let's take a little step back and let's talk about cases in which surgery is a possibility. And so, because I think what we've mostly been talking about are second opinions, where it's like, what treatment are you going to get? And maybe surgery falls under that umbrella of treatment. But when you have a surgery, you've got a number of different players in there. And I think the experience for a lot of cancer patients who are fortunately have their cancer caught early, where it's local, their primary care physician, sends them off to the medical center to get diagnosed, and then they're going to meet with a surgeon. And so, should people be thinking about a second opinion at that point with a different surgeon, or get second opinion in general? I'd love to hear you just talk a little bit about when somebody's in that kind of local cancer, surgery is an option. What should they be thinking about?
Yeah. There are cancers where surgery only is fine, is a good idea, because those surgeries, we believe that that's the case when those surgeries are going to lead to a cure 80% or more of the time for that patient. In all of the other cases, and it's most cancers, we would call those as high risk. Either that even though if there can be a surgery, the cancer is likely to come back after the surgery, or that tumor is already spread at the time of the initial diagnosis beyond what would be surgically curable. And so therefore, you'll need other therapy, either in combination with the surgery or instead of the surgery, or you need the therapy before the surgery. And so all of those things are real and happen today. And it's really important for patients to know that even if they're just being sent to a surgeon, because that's what the system sort of automatically does, because you need a diagnosis, go to the surgeon, they'll get a diagnosis, okay. And while they're in there, they might take it out, okay. Yeah. But again, what's better is to get an opinion from whatever center it is that you're going to. Again, prefer to be an NCI accredited cancer center, but whatever one you're at, get an opinion from the surgeon, but also get an opinion, the same visit or close to it, from a medical oncologist and a radiation oncologist. Those are the three that basically treat every patient in every way that center knows how. And so by getting those three in basically before anything is done, you'll have the best chance of really assessing, will surgery be it alone? Will I need more than just surgery? Will I need medical treatment, any kind of chemotherapy or other medicines that are used? Will I need radiation? And how can these come together to give me the best possible outcome? And that I don't think is part of the system today, sort of understanding that. Now, some patients get it because they ask for a tumor board. And if anyone asks, I'm going to bring this to tumor board, thank you very much. Yes, please do. Because at the tumor board is when all of those doctors basically get in the same room. But patients can actually execute on their own tumor board and not have to be invited or have to have it happen to, meet on that day of the week that they happen to be getting seen, by asking to get a referral to each of those 3 doctors at the same medical center. And of course, when they're with Sagely Health, we may send them to other medical centers as well. But at least that's a step better than what I see most of the time happening.
Okay, so just to recap that. So if you're meeting with you've had a diagnosis, you're meeting with a surgeon, you can turn to that surgeon and say, I would like a referral to a medical oncologist and also to a radiation oncologist to see what they think.
You can ask the surgeon. You can also ask your primary doctor, the one who's sending you to the surgeon, say, hey, doc, that's great. Can I also get a referral to the same center's medical oncologist and radiation oncologist at the same time?
Excellent. That makes a lot of sense. As a side note, I mean, we see a lot of patients at Sagely Health who end up at our doors. They had a surgery. They were told this surgery is the best. It never comes back after this, and it has come back. And in a lot of those cases, a radiation oncologist and a medical oncologist were not brought in. They was just, cancer found, cut it out. We'll see how it goes. And I think that you never, just to make it clear, it's hard sometimes to know if all the cancer was removed through a surgery at the time of the surgery. It's just, it can be just incredibly difficult because we're talking a matter of cells.
Well, right. And the fact is the surgeon can't see it, right? These are microscopic cells. So they do the best that they can do. They take the best shot that they can take. But again, we know the statistics. And so if the risk is high, again, unless the risk is very minimal, stage 1 breast cancer, sure. Surgery, even there, the lumpectomy, plus or minus some radiation. And so again, but unless it's really very clear, you want to, as the patient, you want to do everything you can do to make sure that this has as little chance of coming back as possible. Tumors that come back are automatically high risk, and it almost doesn't matter where. And tumors that spread outside of their local area are high risk, and it almost doesn't matter what kind. There are some exceptions, but in general, again, we try hard to make sure that if we have a patient come to us early, and we love when that happens, we get them the best treatment up front, even if it's more than what they want or expect, because the risk of it coming back later is much lower. And that's what we're going for.
Yeah. So along that line, when there is an unfortunate recurrence, a cancer that felt like it had gone away, that it had been dealt with, and it comes back, I mean, I would say, is that another candidate for a second opinion? I mean, does that kind of puts you in a different boat, right?
Yeah. And yes, absolutely. And not only is it an opportunity for a second opinion, but for us, again, we do it a bit differently than, the routine sort of the system as created. So what the system would do is say, well, you've recurred or relapsed. Now you go to the medical oncologist for treatment, and maybe the radiation oncologist, if the medical oncologist says so, and basically proceed that way. And again, the medical oncologist is then looking up that NCCN. We like to do it a little bit differently. We believe more in a team approach from the very beginning. So let's just not see the surgeon. Let's get the medical oncologist and the radiation oncologist in the room to begin with. And then let's put a few other experts in there as well, oncologists or surgeons at other cancer centers, and create our own sort of virtual tumor board. And you could do it formally, but you could also do it informally, and it works just as well. And having these other ears and having almost a committee of advisors for a cancer patient is when we believe cancer patients do their best. So at the end of the day, we recommend, yes, every single time there's new information that cancers come back or grown. Obviously, if it disappears and never comes back, you don't need anything more. But, if it does come back, then, certainly each of those times we want to re-ask the question, who are the best people to have in the room at that point as advisors to this cancer patient? And then what is the best treatment that comes out of that discussion for that cancer patient to get at that moment?
Makes a lot of sense. I want to talk about kind of close with a couple objections. I was doing a little reading on some studies on the effectiveness of second opinions when people do get second opinions, just in medicine in general. So some of the objections, the reasons that people don't get a second opinion, is they're worried about losing time. Do you have any response to that? I mean, is that should be a worry of a cancer patient, losing time by going and getting a second opinion?
Yeah, I understand why patients can think this way. It seems like, it's been taking forever to get the diagnosis, and when they have it, they just want to rush to get something. They may have had loved ones who who failed to act, and therefore, passed away because they didn't get treatment in time. That being said, and I'd say the system also doesn't help. They'll often hear those comments from the oncologist or the surgeon that, hey, we don't have time to wait here. Let me get you in tomorrow or next Monday or whatever, and we'll just get this thing out. But I would just caution folks to take a step back. And unless they have there's a very limited list. I think the one that we talk about is Burkitt's lymphoma, which happens in children in Africa. So, unless you have Burkitt's lymphoma, it can happen other places, but, unless you have that diagnosis, then you need treatment right away. And guess what? It's like 95% cured. So, other than that, really you have time. And I'm not talking about months. I'm talking about a week to 2 weeks to a month. And I think properly assessing and going through that phase with a second opinion will lead to a better outcome than rushing in to do whatever is in front of them as a next step. Again, if everyone agrees, then proceed forward. But usually it's a very good step and a necessary one in order to get that best outcome.
And I guess I would say also that if you did go to an oncologist and you began a frontline treatment, so maybe you were given a chemotherapy, that doesn't mean you're out of the running for a second opinion. Because there's a lot of times when there may be even the oncologist might tell you, this is just our first line, this is where we're starting, and that may not preclude you from getting a second opinion. It may not preclude you from entering a trial. I mean, that's still available post kind of first line treatment if necessary.
Absolutely. And again, we will recommend and guide patients strategically to start therapy when they need to start there, or when, it may be that, getting some therapy as a gateway into the innovative therapies. They have certain rules. And so, in those cases, start on the standard therapy. And then while you're on that, when you're feeling good, go and see some of these second opinions, so that if you should need it later on, you're already set up to know what comes next. If you don't need it, oh well, but you'll have been glad you spent the effort to prepare, so that, when it comes time to get a scan, you're not thinking to yourself, gosh, what if this thing comes back? I asked the oncologist what they do. They kind of, I don't know, let's just see. Hopefully that won't happen. But if it does, we'll talk about it then. This sort of thing. I've got options here, here, and here. Okay. I hope for the best. I would love to best. We hope so too. But if not, we've got a backup plan that's ready to go. And to me, that's the best way to approach cancer.
So the last reason I just want to talk about that people say I don't get a second opinion is they don't want to hurt the relationship with their oncologist. And I can understand that. I mean, cancer is incredibly complicated. It is a very serious situation, and you just want to trust your oncologist. So how would you kind of talk to a patient who was kind of thinking about a second opinion, but was really kind of worried they were going to hurt the relationship with the oncologist?
Yeah, no, and again, this is it's reality, right? And it's understandable, right? You have a deadly, or the specter of deadliness, of a cancer, and it's really scary. And you've got a person who's been identified as your lifeline. And so, and you're not an oncologist. So, where do you come to challenge, even if gently, what that doctor's saying? Again, and the system won't discourage you from that, but we will, because the fact is that, as much as, that oncologist is wonderful, and they're all wonderful, but they're limited in their choice of options based on the NCCN and standard care on one side and innovative therapy on the other. And we know that innovative therapy is unlikely to be in their hands on a random basis for you. And therefore, best to say, hey, doc, I got these ideas from Sagely Health or an advocacy group, wherever you got them from. Do you think they're reasonable? They're reasonable to consider at this point? Can I go and I would like to go and talk to these other doctors about this just to see. I understand you don't have it, but that is something that I would like.
Gotcha. All right. Well, I think we're going to wrap it up there. This has been great. So if anyone is interested in getting information on second opinions, on how we go about doing that, how to access innovative therapies, we're available. Just reach out on the website, and we'll be doing more of these webinars. If anyone does have topics they'd like to have us cover, please let me know. Once again, you can reach us through the website. So
Great.
Thank you, Dr. Sager. This has been great. And
All right.
I look forward to our next conversation.
Me too.